I'm going to rattle some, but is that too loud? That's a, no?
It's not too loud?
Okay. I'm going to move around. It's going to shake a little bit, but thank you very much, Greg and to the WCMS for inviting me to speak tonight. Thank you guys for coming. I'm really excited to talk about what you want to hear about. I got a lot of things I can go on and on about. Dr. Stern and I were talking about beforehand. I did make this title purposely a bit provocative because I'm trying to stimulate thought among the medical staff as to where we're going in terms of rational care and following evidence for taking care of both diabetes and obesity. And there is new data coming out, really even in the last couple of years, about the effectiveness of these tools, specifically for obesity, specifically for diabetes as well as just diabetes with obesity. However, just to clarify a couple of things on this, most effective does not mean only effective. I could also have titled it most invasive treatment because it certainly is more invasive than other things, but that being said, some of the pills that have been taken off the market may have actually been more dangerous than having surgery, so but they weren't invasive particularly. Secondly, for diabetes, a lot of people with type 1 diabetes in the US these days actually have a component of insulin resistance, but this is mostly type 2 diabetes that we're talking about in these studies. And it's actually, I can get off into the science of that, teasing apart exactly type 1 and type 2 and people who have type 2 with a factor of type 1, a component of type 1 in them. It's called, what is it, LADA, late adult onset type 1 diabetes. They're late autoimmune diabetes in adults or something like that. So there's type 1 that doesn't all come on in juvenile. And that can confound some of our studies as well because those people may be resistant. I think it's over there, yeah. I don't, if I got one, I'll definitely. I think I turned it off.
Yeah.
Yeah. Why don't we turn it on? I can talk loud. Can you guys still hear me if I project? Let's do that. All right. Yeah, it's more in my ear. I'm talking to myself on that thing right behind me. So anyhow, some caveats, but these are things. This is the great thing about having a dialogue. You know, Dr. Stern is the president of the County Medical Society, and as an advocate for this, I'm trying to get the County Medical Society to start a task force and have this be one of his public health. Certainly, it's a public health epidemic. It's just not an infectious epidemic. And these are dialogues that we all have to have as docs, but also as a community, because the county doesn't just work for the docs; it works for the community. And so I thank you guys for being here for that, and I would welcome your questions, and we always get to refine things as we do that. Page up or page down?
Page down. The bottom button. Maybe your computer's talking.
Probably so.
Yeah.
So I just we always when we give talks to each other, we always have to disclose our conflicts of interest financially. And I don't actually have any investments or anything like that are conflicts of interest. Nobody pays me particularly to be on the speaker's bureau or anything. However, I am a surgeon, and I think I have a primary conflict of interest. I get paid to do surgery. So I want to disclose that. However, I get paid to make people better with surgery, not to just operate, as far as I see. You know, our mandate is not to just create operations, is to help. To use operations as tools to help people maintain better overall health. And this is something we talk about a lot in weight loss surgery as well, is we're not trading the scale. Sometimes people get a little hung up on where the numbers are, and definitely we want to track numbers just like we track blood pressures and we track temperatures, but it's your health that we care about, not just the number on the scale. I was blessed in Duluth to be able to be the director of the program there. We've got over 2,500 people under treatment. I didn't operate on all of them. Have partners and team members, medical docs, and allied health professionals. A big team, and that's really the best way to do it. Was able to take them through Center of Excellence, which I'm not going to talk about too much tonight, but Center of Excellence status will have something to do with payers in terms of Medicare, Medicaid, and it's something we'll have to get established here in Bellingham because we really are very early on the productivity curve And I won't talk overly about that, but information sessions, I'm sure the other docs who come to town, and I'll be talking about that in those info sessions. I have a lifelong battle with my weight, really since kindergarten, first grade, you know. I won't talk too much about my overall battle, but I did have sleeve gastrectomy just over 2 years ago, and it's been very effective for me so far. It is a lifelong tool, so you don't count yourself as a success ever, but so far so good. It's been very helpful. I also do have these other non-financial, but they are interests. The ASMBS is the American Society for Metabolic and Bariatric Surgery, metabolic being diabetes disease, cholesterol diseases, heart disease risk factors. And I'm the state access to care representative, and so I am going to be, you will see me wearing that hat in the community, trying to advocate for patients to be able to have access. And I had a phone call with Peace Health even today to talk about coverage for Peace Health employees, and you know how we can refine that process and make it better. And then also this last year I joined the National Advisory Board for the Obesity Action Coalition, which is a much broader organization than ASMBS, and it really is. It takes on the entire disease of obesity, from what Dr. Stern and I were talking about earlier in terms of community setup, in terms of how tax policy is in this country and business support policy, and not just a matter of medical weight management, if you will, but managing weight for the whole country, if you will, and really even for the world. Right now they're mainly focused on the U.S., but they definitely work with other organizations. I encourage you all to join. It's just an advocacy group like the American Diabetic Association or the NRA or whatever. You know, you're a voice, and your voice is critically important, because this is one reason why they're excited to have me as a patient as well as a surgeon. When surgeons go and talk, or docs go and talk to representatives, we're industry. When you write a letter, when you talk to your representative or make a phone call to even to their staff member, you're a constituent, and it is a huge difference. And the same thing talking with your HR person or your, or people here locally at the hospital. You're a customer of our medical community. Your voice really matters. So I encourage you to join. I'm now able to sponsor memberships. It doesn't cost me as much as it would cost you. So I can, if you fill out a card with your info on it, I can send that in to them with a fairly minimal cost to me and get you a 1-year membership. So if you want to join, please do. Your voice really matters. Okay, so as I've asked around this past week or two with nurses and friends and staff, I wanted to give sort of a big, med school kind of talk, obviously without too many long words or weird concepts, but to really bring the science to you, because I think that's what I've gotten out of some of these mini med school lectures. But more and more people told me they really just want to know what the operations are, and let's don't spend too much time on statistics and data. So I'm going to give you a flavor of this. A lot of these papers are easy to find, but I'll tell you, I do think it is important for you to have the evidence, whether it's for somebody you love who may want to have surgery, or yourself, or just to talk with people about it. You do hear a lot of misconceptions out there, and usually if there's good evidence, and there is in this case, evidence can overcome misconceptions. Dr. Stern and I were talking about certain scientific evidence is going to be refuted by some people because they just don't believe in it. And we all know people who have that kind of attitude where they just don't believe surgery is the right thing, or they just don't believe vaccinations are the right thing. And some people you can't convince with data. But I'll tell you, most family members, most people who love you just want to know that you're doing something safe if you're doing this, and that you're doing it for the right reasons, and that you know what you're getting into. So that evidence, if you can take it to them, is really valuable. We want to talk a little bit about the relative effectiveness also of the different operations and medical therapy, because I think people also are thinking surgery is surgery, and a lap band is the same as a duodenal switch, is the same as everything, they're all the same, and they're really not in terms of their effectiveness. They're different operations. I'm not going to go through all of that again. That's something for an hour-long information session to break down all those details. But I think it's good information for you to at least have as an introduction, and these sheets that Ethicon provides are a good starting point for that. The other tricky thing with obesity surgery, not even with diabetes surgery, it's a new concept, but no other disease has the degree of shame and blame that prevents people from coming and getting help, where you have this issue where most people have tried to lose weight over and over again, year in, year out, and they feel like it's their fault. They internalize that it must be their problem. That if only they had enough willpower, they would beat the disease. And it's very hard sometimes getting people to get the help that they need, because we all have to take responsibility for parts of our health, but nobody chooses this disease. And again, that's about 10 minutes of my normal information session, but it's just a concept to introduce tonight. And it's funny because we do have some blame and shame for cancers or lung cancers and stuff, but it doesn't prevent people from getting their treatment. Nobody says we have to stop. You have to stop smoking for 6 months before we'll give you chemo, right? It just doesn't happen. So there are 2 or 3 slides here I wanted to front load before we talk about operations and guide into details. If you only take home about 3 slides worth of message, this is the most important information, is that this is real in terms of lives lost early and in terms of health degraded. When you start at a very early age, and part of the problem is this: a lot of these deaths are invisible deaths, I call them. They're people slipping away with a stroke at 35, or then somebody else having a heart attack at 55. It's not the same as, one airplane crashes with 10 people on board and it's on CNN for the next 24 hours. 1,000 people die today of heart disease that's preventable, and nobody notices, right? They happen sort of sporadically. But if you look at the number of years of lives lost for a woman who's been heavy since she was, 20 here, that's 7 years of life lost. Not just number of years, as I'll show you, but also quality of life. Now, it's important to note the scale on this next one, because I'm going to go one more beyond that. Life expectancy gain. So it's not just important that weight problems take away years of life. If weight loss surgery just made you lose weight but didn't actually change your illnesses or impact your survival, then it's still nice for me not to be carrying around 90 extra pounds. I definitely enjoy that, but if there was no evidence to show that you got a longer life from having your weight corrected, then that would be a big strike against the concept of having surgery. But they're actually very good with Dr. Schauer, who's the guy who trained me when he was in Pittsburgh. He's at Cleveland Clinic now, to actually show a change in life expectancy. But you'll notice the scale is not quite as high. So I'm probably not going to live as long on average. These are averages. On average, as if I was never heavy. It doesn't reverse all of the damage potentially that could have been caused, but it definitely does make a major difference. And one of the interesting concepts too is we talk about an aging population. 65 for a long time was the cutoff for most weight loss surgery programs, and I've actually now operated on people in Duluth up to age 70 for the right reasons. And if you look at that, people have surgery even in their 70s do gain life expectancy, properly selected. We certainly do bigger operations even on 80-year-olds with aneurysms these days, and elective operations for proven life-shortening disease. Like I said, the problem with these is I could talk about an hour off of each slide, but if you have a question on any of these, please stop.